Have you heard the most commonly used medication for gastritis? Proton pump inhibitors can lead to kidney injury and ultimately lead to chronic kidney disease. So, welcome to Pharma World once again, and today we will discuss in brief how proton pump inhibitor damages kidney. Let's see, the latest prescribing information of pantoprazole in 2022, here you can see in the warning section on acute tubulointerstitial nephritis. So basically, we need to understand how serious this is. In this research paper, it shows the duration of treatment of PPI and the overall time trends for the risk of renal outcomes. The data was collected from National United States Department of Veterans Affairs databases and includes more than 100,000 patients. You can see in the graph the injury towards kidney increases as the duration of exposure increase. The drop in the events following more than 720 days may be due to the smaller number of subjects in this time period. But overall there is an increased trend. More data were seen to be published in the last 5 years, with a risk ratio of more than 1 as compared to subjects without PPI. However, it is important to note that they are case control or cohort studies and or randomized controlled trials. And other limitations are like, quantity and use of PPI prescriptions continuously is limited along with other comorbidities. Even in a recently published data from US FDA Adverse Reporting System, the number of PPI-associated acute kidney injury stands at 3,187 and chronic kidney disease is 3,457. The data evaluated was from 2004 to 2019. And among the PPI, dexlansoprazole has the highest OR for both acute kidney injury and chronic kidney disease. But, I would rather say it's not ideal to compare between the various PPI as the prescription numbers are different for all the drugs and there may be bias associated with the analysis. Coming to mechanism of action, currently, the most popular theory for the development of CKD with PPI use is a complication of PPI-induced AIN. In the largest case series to date, only 13 out of 133, 14%, biopsy-proven AIN cases were attributed to PPI exposure. Given that AIN is an overall rare cause of kidney disease, 2% to 3% of all kidney biopsies, it is unlikely that PPI-induced AIN could lead to enough cases of CKD to make a statistical difference. If we venture the molecular pathway, PPI promotes necrotic cell death in cultured proximal tubular cells. This is associated to an early decrease in ATP levels and an early increase in mitochondrial ROS production, suggesting mitochondrial injury. PPI-induced necrosis may lead to the release of cell debris that may facilitate the development of an immune response underlying the observations of acute tubulointerstitial nephritis cases reported in omeprazole-treated patients. PPI-induced hypomagnesemia is another mechanism that has been purposed for the development of CKD. Low magnesium levels have been strongly linked to increased risk of cardiovascular and all-cause mortality in patients with CKD and end-stage renal disease. However, there is a paucity of data showing hypomagnesemia as a direct contributor to CKD progression. Unfortunately, most of the studies on PPI use and CKD did not have a magnesium level available in order to answer this question definitively. So to prevent such outcomes, there are some guidelines and this is one of them. The crux is that to minimize the excessive use of PPI unless warranted. So, what is the safe duration of treatment for PPI? It is not available yet. More data will be required for an answer. Please share if you have come across of renal injury post-use of PPI for a long term. And if you like the content, please like and subscribe to my channel.